Good afternoon, everyone. From the Department of Surgical Discipline from Surgery Unit 1, under the guidance of Professor Sunil Chumbar, we are presenting the CCR of Man to Be. So, title is self-explanatory. We'll discuss about all the presentations, how we work up the patient and the management. So, these are all the presenters. I would like to invite Dr. Komal to start the case.
Thank you, sir. Our patient was a 28-year-old gentleman who was a resident of Patna, Bihar. He presented to us with complaint of anterior neck swelling for past 18 years. It was a spontaneous and insidious in onset, and it was gradually progressive. There were no features of hypothyroidism or hyperthyroidism. There was no dyspnea or dysphagia. He also had complaint of multiple nodules over the eyes, lips, and mouth over past 15 years, which was spontaneous and insidious in onset. He recently started complaining of episodes of palpitations, which was associated with feeling of impending doom. They used to subside without any medication. There were no aggravating or relieving factor, and recently they had increased in frequency to daily episodes every day. There is no history of any medical or surgical intervention. He has history of poliomyelitis in his early childhood. His personal history was suggestive of history of constipation. There is no history of malignancy or thyroid disease in the family. His father died in a road traffic accident 20 years ago. On examination, patient was conscious, cooperative, and well oriented to time, place, and person. He was a thin-built individual with a BMI of 13.62 kg per meter square. His blood pressure in supine position was 124 by 74 millimeters of mercury, and in standing position it was 116 by 72 millimeters of mercury. His heart rate was 76 per minute and 80 per minute in standing position, and his Karnofsky performance scale was 80. He had bilateral cervical lymphadenopathy. On head-to-toe examination, there was a divergent squint of the left eye, and multiple palpebral conjunctival nodules were present. There was conjunctival chemosis, and he had diminution of vision in both the eyes, and there were features of glucomatous optic neuropathy in both his eyes. There was no exophthalmos or thyroid eye signs. He had multiple nodules over the lip, buccal mucosa, and over the tongue. He also had features of marfanoid habitus, with his arm span more than his height and lower segment length more than his upper segment length. On local examination, there was a butterfly-shaped swelling of 15 into 9 centimeter over the anterior aspect of the neck, which was moving up on deglutition. This swelling was firm in consistency, and all the borders were palpable, including the lower border. The trachea was deviated towards the right side. He had bilateral cervical lymphadenopathy, and there was no bruit over the thyroid swelling on auscultation. On his CVS examination, no murmur was heard. On his CNS examination, on the left side, there was fourth cranial nerve palsy, and he had a lurching gait. His respiratory examination suggested a trachea which was deviated towards the right side. Otherwise, it was normal. His abdominal examination did not reveal any palpable mass or hepatosplenomegaly. So based on the clinical findings, we made a clinical diagnosis of a thyroid swelling with multiple cervical lymph nodes, with episodic palpitations, with multiple mucosal neuromas and marfanoid habitus. So we suspected the patient to be having Men-2B syndrome, and we performed the further workup based on this. On his blood investigations, his CBC, LFT, KFT, and PTINR were within normal limits. His thyroid profile was suggestive of a subclinical hypothyroidism. His CAA and calcitonin were highly elevated, which are a marker for medullary thyroid carcinoma. We first performed 24-hour urine fractionated metanephrines and normetanephrines, which were normal, but his free plasma, metanephrine, and normetanephrine were elevated. His echocardiography suggested normal left ventricular function without any features of aortic regurgitation, aortic annular dilatation, or dissection of the aortic root, and indirect laryngoscopy suggested normal function of the bilateral vocal cords. I'll invite Dr. Rachna to present the imaging findings.
We're having this CT scan images, contrast and CT scan at the level of thyroid gland, in which we can see that there is heterogeneously enhancing mass lesion, which is involving both the right lobe, left lobe, as well as the isthmus. So basically, this lesion is diffusely involving the thyroid gland. This lesion is causing significant compression of the trachea. As such, there is no extrathyroidal extension seen. Posteriorly, the fat with bilateral carotid vessels are well maintained. We are also having necrotic lymphadenopathy, which is showing the same enhancement pattern as that of the thyroid gland. In the mediastinal window, we can see that there is necrotic lymphadenopathy. They present at both the hila, and in the lung window, there is well-defined pleural-based nodule with this feeding vessel sign suggestive of metastasis. In the abdominal section, we can see that there is well-defined homogeneously enhancing mass lesion, which is present at the suprarenal location on the left side, suggestive of pheochromocytoma. As such, there is no internal calcification or fat density noted within the lesion. In the axial MRI section of the brain, we can see that T2 isointense lesion with minimal perilesional edema seen in the left temporal region. And this lesion is showing homogeneous pattern of enhancement, and as the lesion is dural based, it is suggestive of a meningioma.
I will invite Dr. Angel from nuclear medicine to present the findings of the functional imaging.
Good afternoon, everyone. A pre-op iodine 131 MIBG scan was done. In the planar images in figure A, we can see there is increased tracer uptake in both lobes of thyroid gland, as well as physiological uptake in the salivary gland, myocardium, and liver. In the posterior images in figure B, we can see both the adrenal glands are taking uptake, in which the left adrenal gland is taking more uptake than the right. In the serial transaxial images of the abdomen section, we can see there is a nodular lesion in the left adrenal gland with increased uptake, as well as the right adrenal gland is also taking uptake with no definite lesion in this. In the next sections, we can see a mass lesion involving both lobes of the thyroid gland and isthmus with heterogeneously increased uptake. A gallium dotanol PET-CT scan was also done pre-op for better lesion characterization. In this, we can see the thyroidal mass is taking uptake. In the figure A, we can see a thyroid mass taking uptake, along with a few cervical and mediastinal lymph nodes with increased tracer uptake, and left adrenal lesion with increased tracer uptake and physiological uptake in the pituitary, liver, spleen, and the excretory system. We can also see a focal tracer uptake in the left temporal lobe region. In the transaxial images, neck region, we can see a heterogeneously enhancing lesion involving mass involving both the lobes of thyroid gland, and a tracer of it, right level 5 lymph node. The abdominal sections, we can see a nodular lesion in left adrenal gland with increased tracer uptake and physiological uptake in the right adrenal gland. In the brain sections, we can see a focal increased tracer uptake in the left temporal lobe with no definite lesion in the CT sections. And in the lung sections, we can see a parenchymal nodule in the left lung lower lobe. These findings were suggestive of likely suggestive of medullary thyroid carcinoma with cervical and mediastinal lymph node metastasis, lung metastasis, left adrenal pheochromocytoma, and an incidental finding in the brain likely to be meningioma. Post-op scan after left adrenalectomy, again iodine 131 MIBG scan was done, which showed increased tracer uptake in the right adrenal gland. These findings are suggestive of likely suggested to be MTC with right adrenal pheochromocytoma. So this one is post-op, sir, for after left adrenalectomy. No, sir, only left adrenalectomy.
A fine needle aspirate cytology was performed from for the patient. It was suggestive of Bethesda 6 and medullary thyroid carcinoma. We performed genetic testing for the patient. As we know, red gene is responsible for MEN2A and MEN2B syndrome. In our patient, the 918 codon, which is responsible for MEN2B syndrome, was found to have a missense mutation, and the ATG codon was replaced by a ACG codon. And in this patient, the methionine amino acid was replaced by a threonine amino acid. So our final diagnosis was MEN2B syndrome with medullary thyroid carcinoma, with bilateral pheochromocytoma, with multiple mucosal neuromas and a meningioma. So we planned to operate this patient in a staged manner. We first performed left adrenectomy, followed by a repeat MIBG scan, followed by right adrenectomy and total thyroidectomy with the central lymph node dissection and bilateral modified radical lymph node dissection. I'll invite Dr. Manpreet to comment on the anesthetic implications of the case.
Good afternoon. Anesthetic management of MEN2B is very challenging. Each individual component poses unique challenges. Presence of pheochromocytoma results in circulating catecholamines, thereby causing intraoperative hypertension risk. Presence of large thyroid with tracheal narrowing, which was deviating the trachea to right, making ventilation which would be difficult. This large thyroid was also abutting right internal jugular vein, so there was risk of increased intraoperative blood loss. And to add to it, we could not insert a neck central line, so we resorted to PICC line. Presence of meningeal neuroma raises concerns of raised ICT, and marfanoid features itself was associated with pectus carinatum in this case, thereby pulmonary implications. The goals of preoperative preparation are first the pharmacological preparation. Always we do alpha blockade followed by beta blockade. And once there is alpha blockade, there can occur orthostatic hypotension. So the fluid intake is increased to 2 to 3 liters per day, which reduces the incidence of orthostatic hypotension and post-excision hypotension. The entire preparation not only controls the symptom, but also reduces risk of intraoperative hemodynamic crisis, attenuates the response of vasoconstriction, and restores the volume, vascular volume, and thereby normalizing the hematocrit. Anesthetic management is dependent upon the surgical approach and positioning. This patient was taken for staged procedure with left adrenalectomy followed by right adrenalectomy and thyroidectomy. Preoperative preparation is very important. The OR is prepared with multiple infusions and vasoactive drugs. Pre-induction, adequate angiolysis is done. Monitoring includes multimodal monitoring like 5-lead ECG, invasive monitoring, central venous cannulation, and multiple lines being connected with vasoconstrictors as well as vasodilators for different time interval uses. We use original intrathecal morphine and high dose of fentanyl to avoid the sympathetic surge which occurs during different time points. And we were prepared with norepinephrine infusion also for post-operatively once there is fall in blood pressure because of the removal of the pheochromocytoma. At different time points, there is risk of intraoperative hypertensive crisis during induction, mask ventilation, intubation, positioning, incision, and creating pneumoperitoneum and tumor manipulation. Once the tumors are removed, there is risk of norepinephrine crisis, and which was managed by volume replacement by replacing the volume to restore CVP up to 10 to 12, and then adding on norepinephrine later. During the first surgery, patient was extubated on table, while during the second surgery, after the removal of the thyroid, since it was adherent to trachea, elective tracheostomy was done, and patient was shifted to ICU for further management. Now I invite Dr. Suneha for the discussion.
Coming to the surgeries performed, patient underwent 3 procedures in a staged manner. First, left adrenalectomy was performed, followed by an iodine 131 MIBG scan, followed by the light adrenalectomy and the total thyroidectomy. So, for adrenalectomy were performed by the laparoscopic transabdominal approach for both the right and left side. These are the intraoperative imaging. So, first video, this shows left adrenalectomy being performed. So, this is the left renal vein, which is draining into the left adrenal vein, draining into the left renal vein. So, this will be we apply 3 clips and division of the left adrenal vein is done. This is a very crucial step during the procedure because following this step, patient can have fall in blood pressure. So this is positioning for the laparoscopic right adrenalectomy. Patient is positioned the left lateral position. This is the video showing the right adrenalectomy. So initially, dissection is done from the undersurface of the liver, followed by clearance from surface of inferior vena cava. This is clipping and ligation of the right adrenal vein, which drains directly into the IVC on the right side. Further dissection and tumor resection is being done. After the right adrenalectomy was performed, patient was repositioned into in rose position, and thyroidectomy with central compartment lymph node dissection and tracheostomy was done in the same sitting. Standard Cox's incision. these are the specimen findings and the intra findings. So this first imaging shows the left adrenalectomy, where a well-defined 2 cross 2 centimeter adrenal tumor was seen in the left adrenal gland, free from the adjacent structures. This is the right adrenalectomy specimen, which shows a small 1 cross 1 centimeter nodule, the right adrenal gland. And this is a total thyroidectomy specimen with bilaterally enlarged lobes, left more enlarged than right. This is a cut specimen. And so intraoperatively, we found that the right lobe was firm, adherent to the lateral aspect of the upper trachea. So this, the decision was taken to do an intraoperative tracheostomy, and due to the long-standing nature of the goiter. Also, multiple hard calcified nodes when seen adherent to the tumor. Those in the hospital, initial workup was done with imaging and biochemical workup. Departmental consultations were done with ophthalmology, neurosurgery, and endocrinology. Patient was prepared with the alpha blockade using taxosin. After the left adrenalectomy, repeat MIBG scan was done, and alpha blockade was withheld during this time due to the hypotension. After the second sitting procedure of adrenalectomy plus thyroidectomy, patient was kept off all hypertensives. He I started on IV hydrocortisone, which was tapered and was then put on oral tap prednisolone with hydrocortisone. He was also weaned of the tracheostomy, and by post-op day 80, levothyroxine supplementation was started during the post-op hospital stay. Now I invite Dr. Hina to present the histology and imaging. Thank you, ma'am. So I'll be summarizing the histopathological findings of this case. The total thyroidectomy specimen revealed grossly enlarged lobes of both lobes of thyroid, and capsular breach was identified grossly. Portion of right lobe was sent separately as the tumor could not be removed in mass. And as we can see on the cut surface, there are multiple tumor nodules, the smallest being 0.2 centimeters and the largest being 3.5 centimeters on the right lobe, and a single tumor was identified in the left lobe. On histopathology, we can identify a tumor which is arranged in solid nests as well as in trabecular architecture, with the individual tumor cells having plasmacytoid to ovoid a moderate amount of cytoplasm, ovoid or to round nuclei with coarse chromatin, small nucleoli, and very prominent cytoplasmic illumina or containing some sort of mucin vacuoles. Yes. So these are the cytoplasmic illumina. Some of them contain some secretions. And in the background, we identified C-cell hyperplasia as well. Primary C-cell hyperplasia. This is a necrotic lymph node which displayed metastasis from a similar tumor, as well as the special stains were performed for demonstration of intracytoplasmic mucin within those vacuoles, and AB-BAR stain reveals neutral mucin in these cells. Immunohistochemistry was performed for total calcitonin protein, and the tumor cells, including the cells which were secreting containing intraluminal mucin, also showed calcitonin positivity. Ki-67 labeling index was raised and was around 25%. The left adrenal gland, which was suspected to have a pheochromocytoma, was also enlarged, and cut surface showed a well circumscribed tumor, which was yellowish brown in color. In addition, the rest of the adrenal medulla was diffusely enlarged, and normal medullary thickness, which is less than 1/3 of the total thickness of the adrenal cortex, was considerably enlarged in this case, suggestive of diffuse type of adrenomedullary hyperplasia. On microscopy, we are able to identify that this is the normal cortical thickness, this is the medulla, and it is markedly enlarged in comparison to the cortex. In addition, there was a ill-circumscribed tumor within the adrenal medulla, which showed Zell-Wallin architecture and higher power, composed of large polygonal cells with amphiphilic cytoplasm, ovoid nuclei with coarse chromatin, and inconspicuous nucleoli to small distinct nucleoli, with features suggestive of pheochromocytoma with diffuse type of adrenomedullary hyperplasia. The right adrenal gland on cut surface showed multiple nodularities within the medullary region, and no definite tumor was identified grossly other than those small nodules. On histopathology, we identified multiple microscopic foci with histomorphology suggestive of a thyroid tumor, in addition to adrenomedullary hyperplasia. This tumor was immunopositive for calcitonin and pine cytokeratin, and the deposits were identified within the cortex. This is the normal adrenal cortex. This is the tumor deposit. So final diagnosis was
medullary thyroid carcinoma with metastasis to right adrenal gland, with pheochromocytoma of left adrenal gland, and adrenomedullary hyperplasia both.
Thank you. Good evening, everyone. So we had a patient who had with the final diagnosis of MEN2B syndrome with M918 mutation in RET gene with the components of medullary thyroid carcinoma, which was multifocal, and it was with pheochromocytoma of the left adrenal gland and also adrenal hyperplasia of the right adrenal gland with metastasis to right adrenal gland, and with non-endocrine features of multiple mucosal neuromas, marfanoid habitus, and an incidental finding of meningioma. So to start with the review of literature, our patient himself was like a literature who had all the symptoms. This is a rare disorder which has both endocrine and non-endocrine features. It was coined in 1975 as neuroma phenotype. There are various synonyms for it, and it is commonly called now as Williamson-Pollock syndrome. These features of patient having symptoms have been described by a pathologist, J. Aidan Carney, and the association between codon 918 mutation was found out in 1994. The clinical presentations are with the endocrine of MTC, that is the thyroid swelling, and with the pheochromocytomas. These pheochromocytomas can be symptomatic or asymptomatic, can be unilateral or bilateral. Sometimes with the paraneoplastic syndromes of diarrhea or ectopic Cushing syndrome can be present rarely. The non-endocrine features are patient having mucosal neuromas, having high arched palate, and then having musculoskeletal disorders, having intestinal megacolon or with constipation coming, and patients having ocular neuromas. These are non-endocrine features. The importance of genetics. The more than 95% of the time it is common in M918T mutation. Now the association of this is there is genotypic with phenotypic correlation. So more than 95% of the time it is common in 918, and in less than 5% it is 883F mutation. The other rare mutations are with the double mutations, in whom there are absence of these non-endocrine features. Once we have a patient with MTC, we should be able to diagnose between or differentiate between 2A and 2B. In an MEN2A, there will be presence of hyperparathyroidism, whereas it is absent in MEN2B. The non-endocrine features are cutaneous lichen amyloidosis in MEN2A, whereas all this marfanoid and ganglioneuromas in MEN2B. And the other importance is MEN2A is comparatively less aggressive compared to MEN2B, and MEN2A is commonly seen in teens when compared to infants, which is seen in MEN2B. The importance of detection in early childhood, because the prognosis is good if patients are diagnosed before the appearance of MTC. So parents might complain of having children crying without tears, which can be confirmed by Schimmer's test, and patients can be having chronic constipation. Suppose if the baby has both intestinal and musculoskeletal features, baby can be having failure to thrive. And with all this, there should be high index of suspicion. These will not cause problem, but they lead us to diagnosis or suspicion for diagnosis. Now, how do we manage for already a diagnosed case of MTC? We have to rule out a functioning pheochromocytoma. So biochemically by plasma metanephrines and normetanephrines, and imaging by CT and functional imaging to confirm that it is pheochromocytoma. And for the thyroid, basal calcitonin levels, which is required for the basal and further follow-up, and CECT neck and chest. So once it is diagnosed, if patient has a pheochromocytoma, we have to treat pheochromocytoma with preoperative adequate optimization, that is alpha blockers followed by beta blockers with adequate volume expansion, and laparoscopic adrenalectomy or even open adrenalectomy can be done. Once adrenalectomy is done, either in the same stage it can be done, or it can be done in a stage procedure like how it is done in our case. And for thyroidectomy, total thyroidectomy, depending on the neck node status, prophylactic neck dissection can be done if there are no nodes, but if there are nodes, central and ipsilateral, at least lateral neck dissection should be done. There is no role of radioactive iodine therapy in medullary thyroid carcinoma. If patient has got a significant tumor or there is a progressive disease, tyrosine kinase inhibitors can be started. The FDA approved drugs are vandatinib and cabozantinib. The non-endocrine features are the intestinal manifestation, which might require treatment, decreasing the quality of life. Most of the time they can be treated conservatively. If not avoidable, the part of the colon which is dilated can be resected. But in this, prophylactic total colectomy is not a viable option, as there will be a diffuse ramification in the colon. Now, the importance of genetic testing is the indications first is the first degree relatives of patients with proven hereditary MTC and parents whose infants or young children are diagnosed to have MTC. There is an option for prenatal testing, that is, it can be done in first trimester with chorionic villus sampling, in second trimester with amniocentesis. There is also an option for pre-implantation genetic diagnosis. Suppose if the parents do not wish for it, they can be offered for counseling and genetic testing of their child. Now, the importance of all this is they can be risk stratified. The highest risk is with M918 as of our patient, and the high risk with meant to be is another is 883. Once we diagnose this, suppose if we have a patient with 918 mutation, patient preferably or the baby should undergo total thyroidectomy within the first year of life. Suppose if it is 883F, we can prolong it for 3 years of 5 years. Another important is to screening for pheochromocytoma, it should start by the age of 11 years. And the presence of pheochromocytoma must be ruled out in a woman who is planning for pregnancy. Now, how do we follow? These patients, they no need to suppress TSH. So they can be given with replacement thyroxine dosage. If they undergo bilateral adrenalectomy like our case, glucocorticoid lifelong and mineral corticoid replacement has to be done. So the first year post-operatively, we have to first 3 months calcitonin has to be measured and the serum calcitonin doubling time has to be checked. If the calcitonin doubling time is less than 6 months, patient has got a poor prognosis compared to doubling time more than 6 months. And then yearly, we have to get a metanephrine or normetanephrine. The outcome, which is more important. So the most common cause of mortality in MTC, meant to be is MTC. So these patients, they hardly cross more than 40 years of age. This was a German article wherein they analyzed a retrospective study wherein children diagnosed with the non-endocrine features had an overall survival of, the overall survival was better compared to patients who were diagnosed with MTC. Now the significance of our case, it was a long-standing goiter, maybe C-cell hypoplasia leading to MTC, who had a non-endocrine features from childhood which was not evaluated. He had a pheochromocytoma with a bilateral adrenal hypoplasia and the stage procedure was planned, but histopathology showing a metastasis to the right adrenal gland. So to conclude, early diagnosis is paramount and genetic screening is a must in these patients and also in their siblings. Prophylactic thyroidectomy should be done in children and pheochromocytoma should be operated first. Total thyroidectomy with a clinically appropriate neck dissection should be done. Overall outcome of meant to be remains relatively poor.
Typical patient with the typical presentation, workup and management. About the surgical management, the pheochromocytoma has to operate first before any surgical intervention. About the 1 stage and the 2 stage, depend upon the pre-op workup, surgical team as well as the patient instability during surgery. With this, I would like to express my sincere thanks to Department of Endocrinology, Nuclear Medicine, Professor C.S. Bal, in the genetic testing, and the Department of Radiology, Pathology, Department of Anesthesiology, Ophthalmology, and the Nuclear Medicine. Thank you.
Last 31 year, we have 11 meant to be, including this one, 11 meant to be. Actually, the people need to be educated about meant to be, and it is 28 years it took the diagnosis and a big institution to the host of physicians involved in the process of diagnosing. You just look at the patient, you know the diagnosis, because the diagnosis is written on the face. Just like Graves' disease, if you have got ophthalmopathy, you know the diagnosis is Graves' disease. Similarly, meant to be, the diagnosis is in the face. You just look the lumpy, bumpy lips and the mucosal neuroma, you know the diagnosis. And it took 28 years. And the survival depends on how early you can take out the thyroid. And it is, unfortunately, he will not be a any cure. And most one point which is not highlighted, you even in the discussion you did mention CEA, which is most important prognostic marker in medullary thyroid carcinoma. If CEA is 1500 and calcitonin is 600, indicating that already the tumor is dedifferentiated. The tumor is going to behave very aggressively. And 918 is available since last 10 years we have been doing in my lab. And we do it free. The ICMR gives us grant. We are doing it for whole country. Anybody sends the sample, we do it free. And all thyroid genetics, we are doing it free at AIIMS. And I am very unfortunate. Another patient came from Maulana Azad Medical College, diagnosed with papillary thyroid carcinoma, which is meant to be. pathologist also missed that they wrote papillary thyroid carcinoma. You look at the patient, you know the diagnosis. So I think all the surgery department, they should put a classic meant to be picture in their department. So all the residents, they go through that, they can see, and then whenever they sit in the clinic, they can make the diagnosis. That's the point I want to emphasize. And the CT scan is only done just to identify the nodes if it is a very early stage. And it's like this patient already stage 4, the CT scan has no, and all these scans and other thing has got no value. Because the patient is too late to be diagnosed, to be saved. It's going to die very early, very soon, very bad, extremely bad. They're called high risk category where 918 mutation is there. They will be diagnosed, they will be dying very shortly. Their calcitonin is good for men to A, not men to B. Nothing works. No. This cabozantinib, hendatinib, we have a few patients we are getting. Fortunately, last month cabozantinib is available from India, but is extremely toxic drug.
Thank you very much, Dr. Bal. We have also presented 5 cases meant to be here, and this is a new team which is have managed this. फोटो लगाने से तो नहीं चलेगा, ऑपरेशन तो करना पड़ेगा. We were planning to do a bilateral or a single stage procedure, and I think Madam was most insistent on that. But there were some issues with imaging, especially the nuclear medicine imaging, so we had to stage it this manner. If there are any questions pertaining to this patient, we will take that up.
The bilateral, whenever you see bilateral FEO, must think of syndromic. This is the standard teaching.
But unfortunately, while we were thinking of bilateral FEO, it did not turn out to be a bilateral FEO. Right. It turned out to be a FEO only on one side. Left the side. Other side had metastasis from the thyroid gland. So that was the confusion which had arisen. No, this is Dr. Saab, this is the first time that we have noted that this has happened. In fact, the issue initially was whether it is unilateral FEO or bilateral FEO. And if it is only unilateral, then you do only unilateral adrenalectomy, you do not have touch the other side. And that's why one stage was done and the re-imaging performed, which showed again an uptake on the other side, contralateral side. Once that was confirmed, then it was not there earlier. So that's why the adrenalectomy was performed, suspecting it to be a FEO, but it did not turn out to be a FEO. No, it's a metastasis from the thyroid cancer. Yes, you want?
Sorry. So there was adenomedullary hyperplasia on both sides, and this particular variant of MTC is amphicrine variant, which is very rare and known to be very aggressive. So this is the first case which I have seen. I joined in 2014. Okay, I don't have much of an experience, but whatever I have seen, this is the first case we have.
Excuse me, ma'am, I have a question from you only. Ma'am, for proving that the right side was a metastatic MTC and not a pheochromocytoma, we only did calcitonin. But few cases of pheo can also express calcitonin. So do we need to do other markers?
Morphology also matters. So
okay,
pathologist is there for that. And calcitonin, yes. He's saying some few calcitonin. So, but yeah, but the location of this, it was mainly a cortical nodule. There were multiple nodules which are based in the cortex. So it was not a medullary origin. We also saw adenomedullary hyperplasia on that side.
Thank you. Thank you, ma'am. Thank you, everyone.